Good afternoon and welcome to Using Data to Prevent Heart Disease and Sudden Cardiac Death. I'm glad that you joined us today. I'm Angela Shippey, the Senior Physician Executive and Clinical Innovation Lead for the nonprofit healthcare team. I'm an internal medicine physician by training, and I practiced as a hospitalist for many years, and I've held Chief Medical and Chief Quality Officer roles. I have been an end user of technology my entire career. I am thrilled to be here today to moderate a conversation between Dr. Nnameka Okafor, who is the Chief Health Information Officer for Memorial Hermann, and Evan Ernst, who is the co-founder and executive director of Who We Play For. One of the reasons why it was so important to have this conversation today is healthcare is a very complex ecosystem. There are many different people, organizations, and industries that work together. There are nonprofit organizations like Who We Play For. There are healthcare providers like Memorial Hermann. There are regulators, there are legislators, there are accreditors, payers, policymakers, and the truth of the matter is all of the decisions that they make for best practices, guidelines, or new information, advocacy, really do impact even the most discrete interactions between providers, patients, and communities. And what's so exciting today about this particular conversation is we get to talk about how advocacy and passion comes together with healthcare providers and comes together to make a difference in how we look at how we might screen for cardiac disease and what it can mean. So if you think about why is it so important to talk about this, one of the reasons is it's all about data. And having data in the cloud that really allowed for new insights and new information to lead to recommendations that could be made for screening. And so we're going to talk a lot more about that. And so whether you're in the room because you love this topic, perhaps you're a sports enthusiast, you're an educator, or you're a parent with a child in organized sports, understanding the impact of screening for cardiac disease is really important. So we're going to get started. And to kick us off, I would love for each of you to share a bit about yourselves and your role, as well as your organizations and their mission. And we are going to start with Nnameka.
All right, thanks for you all showing up here. So as Angela mentioned, my name is Nnameka Okafor. I'm an ED physician at Memorial Hermann in Houston. It is a level 1 hospital, has at least 14 other different affiliated centers around Houston. It serves more than 1.8 million patient encounters. We have over about 60,000 emergency medicine visits, which is one of the locations that I work at as well. We deliver babies. We have life flights that actually brings patients from other institutions down to our hospital since we're a tertiary care. So we manage several other complicated cases. So it is a well-recognized location in Houston. In addition to being an ED physician, I also teach medical students, residents, and fellows because I am part of the academic health system or academic facility. And in addition to ED physician as well, I am the informatics and analytics officer for Memorial Hermann in Houston. And I got into informatics and analytics because right before med school, I was trying to decide whether I go into building video games or becoming a doctor. And I figured I could still do one of those as a hobby without going to jail. So you can figure out which one that was. Thank you.
Well, I'm going to ask you a couple questions about Memorial Hermann. So, you very graciously told us all the things that you do, which is a lot. And one of the things that you do is you're also making connections about what's happening from an informatics standpoint, what it means to the clinical providers, as well as what it means overall to the community.
Yeah. So I guess trying to figure out how I go into that further, show of hands, how many people here are working in a health system? A few. And how many of folks are in the tech industry? Not health system. Everybody else. Okay, so I will use more technical jargon. or the best that I can. But at least if I use any more healthcare stuff, I would explain a little further. So with informatics at our organization, we serve as the liaisons between the technical and the clinical folks. So as I was having a conversation with Evan, we try to make sure that we are using or harnessing the value out of the technology. And it's ideal that my role is combining both informatics and analytics, so we could take a look at the data, understand how best the input or the data entry fields need to be organized so that clinicians and operators use the system and enter data in the better way and use the system appropriately, and that the data we pull out on the back end actually is more accurate or makes sense.
That's great. All right, we're going to talk more about that, but now we want to hear from Evan.
Awesome. All right, I'm Evan, everybody. Nice to meet you. I'm by far the least accomplished and least interesting person on the stage, but happy to share for a few minutes.
Not true.
This is really full circle for me and a couple people in this room. It's really close to a special day, or a really powerful day for us and for who we play for. Our story starts as kids in a small town in Florida, Cocoa Beach, obsessed with soccer, wanting nothing more in the puppy days of trying to win a high school state championship. It's pretty crazy when you look back and you think about how much Kool-Aid when you're a kid you drink on that dream. You watch Remember the Titans, you get hyped up on that Disney movie Will Be Ours. But fast forward through that experience, in our little tiny town, we all had the same pediatrician. We all went through the same cattle call sports physicals at the high school. We played on the same teams since we were in kindergarten. And it's just classic small town America stuff. And then on this day, nearly 15 years ago, we took the field and we watched our best friend collapse and die in a high school soccer field from a detectable heart condition that was missed through a lifetime's worth of sports physicals. His name was Rafe Macron. He was the perfect picture of health. He never had a symptom in his life, which is the case for 80% of student athletes whose first symptom is sudden cardiac arrest. When he went down, he fell to his knee and onto his back, and 20 or so kids that had grown up together since kindergarten looked at each other in pure chaos with no idea what to do. One of our best friends, Clinton, who's in the room, was required to learn CPR through ROTC at the time. So Clinton really owned the situation, started CPR, and a few of us ran through the high school looking for the AED, which ended up being locked behind many doors. EMS got stuck in the mud around a half mile or a mile away, and maybe 10 minutes or later, we got the AED to Rafe and delivered his first defibrillation. The way this works in sudden cardiac arrest, those few people who raise their hands who work in healthcare know, if you don't respond in the first 4 minutes, the likelihood of survival is incredibly small. There's about a 10% survival of sudden cardiac arrest as is. And for Rafe, unfortunately, he died that evening. And a week later, we buried his ashes on our high school soccer field. Every December 1st for 15 years, we woke up and watched the sunrise, as we did when Rafe died that night, and stayed up all night together as a bunch of pissed off, heartbroken teenagers with his family to watch the sunrise. So for us, I think it's Friday morning, December 1st. So we invite you guys all to watch the sunrise December 1st, post a picture, tag who we play for. We've had some good posts from all over the world over the years. But this put us on the path. What we learned, that a few in this room hopefully know, is that sudden cardiac arrest is the leading cause of death in student athletes. It's the leading cause of death on school campuses by far, and it's arguably the leading cause of death in all children. What we learned is that in other countries, like Italy, if Rafe, an Italian kid, had grown up in Italy, he would have had an ECG as a part of his sports physical. It's been required since 1982. In their country, decades later, they reduced sudden cardiac death in student athletes by 90%. In our country, in America, a fine print recommendation for kids like Rafe has left us with a near 0% reduction in sudden cardiac arrest in athletes, in adults, and the young. And we really have no clue how many kids die of sudden cardiac arrest in America. The American Heart Association has reported the same number 6 years in a row until the last 2 years, which was 7,037 who had suffered sudden cardiac arrest. So we have no clue. We know it's a lot. Maybe it's a leading cause of death, but it's definitely close. And that put us on this path. We learned that if we had gone to UNLV or played for the Raiders, we would have had an ECG as a part of our sports physical. For Rafe, he had a condition called hypertrophic cardiomyopathy, HCM. It's the leading cause of death in sudden cardiac arrest for athletes under 30. and that condition is detectable 95% of the time. So if you line up 100 kids who have HCM in Las Vegas, you're going to catch around 95 of them with an ECG read the right way, compared to around 4% of those, 4 or so, with the standard physical and with their pediatrician. So we're obsessed with this. It's been the honor of our lives to work on this, the race family, with parents and groups from across the country who are just like us. Fast forward 10 years, we were able to build the largest heart screening nonprofit in the United States. We've scaled it to 500 communities across the country. We've documented saving over 250 lives. We got to do a little hoopla thing on Good Morning America, present at the American Academy of Pediatrics, and some really special stuff. But how we got here, God bless AWS and the Health Equity Grant. A few years ago, thanks to Clinton, who's our AI genius, we realized the power of this data and the potential it has to take down the biggest barrier to making this a standard of care. So I'll end the TED Talk and give it back to Dr. Shippey.
I love that. And I love both of you talking about kind of where you are, what you're doing, and what data means to you. And we're going to dive into it a little bit more. So we talk a lot at AWS about moving to the cloud being an accelerator. So it can be a business accelerator, it can be a clinical accelerator, it can be an accelerator of knowledge and knowing more. And so I would love for you to talk about a little bit more, Evan, like what did it mean when you put your data in the cloud?
We finally listened to Clinton first. He's been saying this for a really long time. It's so easy to get bogged down in the weeds of everything else that needs to be done. We're a small nonprofit, but it feels like there's just an endless amount of work and exciting opportunities. But for us to pause and to be empowered through the AWS Health Equity Grant initially, and later the Imagine Grant, and some amazing folks like Danielle Morris and Samantha and many more, and Dr. Rowland has been fantastic, and many more, admit that for this moment, who we play for had a chance for a macro impact that's almost beyond belief, that somehow over all these years, with every group like us in the country joining and submitting their data to the cloud, we had the largest database of pediatric and young adult ECGs in the United States, and according to Dr. Antonio Policia in Rome, Italy, probably in the world. So what does that mean? We got a little ways to go to figure out exactly, but if AI keeps expanding exponentially and what's possible, then it probably means we were able to complete the Who We Play For mission a decade later.
That's great. Yes, please. Clap for that. That's amazing. As we just yes, please. And just to give a little bit of context, so the Health Equity Grant at AWS, we believe that it doesn't matter who you are, where you live, what your socioeconomic status is, or what social determinants of health may be in your life, that you should have good and better health. And so we sponsored 40 million over 3 years in order to allow organizations to look at data, access to care, and the impact of social determinants of health and how it can improve care. And so I'm glad that was something that you could take advantage of. As we continue this conversation, I'm just going to put our pictures up in the back, and I'm going to ask Emeka for you to talk a little bit about what are you looking to do as you look at analytics, as you think about patient populations you want to impact, as you think about the future of informatics and care and what's happening at Memorial Hermann. What are you looking to achieve?
So for our organization, we went with AWS for business continuity reasons. So it was easier for us to scale our technology, not waiting on on-prem servers or finding the people to help manage the technology that we have. So moving to the cloud helped us, I'd say, leapfrog basically where we were going to be. Now that our next step is, as you are aware, we are transitioning our EHR from one major vendor to another major vendor. We're going to use that opportunity to move to the cloud, start to integrate other non-EHR technology, wearables, having conversations about remote monitoring, and all of the implantable devices that share data. Our goal is start to integrate all of that information. So integrating data is one of the big things that we're expecting to see, but now we have to do something with it. So the hope, and what we are yet to see, but we know it exists in several other industries, is that we start to summarize that information into actionable insights that we can deliver to our clinicians and operational folks at the point of care in a manner that they understand. So You've seen some of the Gen AI stuff, so let it translate it for me in the way that I understand information. It would be good for that to happen. But then also for our patients, as we discharge those patients and send them home with stacks and stacks of paper, I prefer that we give it to them in a manner that makes a lot more sense. And then we know that just sending them home with stacks of paper is probably not the ideal thing, but they have reminders that ongoing care management while they're at home after they leave the hospital. Those are the things that I'd like to see as we are moving to the cloud.
I know that when we've been talking about this session and getting ready and what you just shared, you want to bring that data to the clinicians in the way they can understand it. You've also talked about you want to make sure patients have data in a way they can understand it. And we've talked about service lines, right? Depending on if it's cardiovascular, if it's oncology, if it's something else. Can you talk a little bit more about how you can get very specific with the data depending on a particular patient population or disease process?
So with our EHR, electronic health record, we manage tons of patients that now we have the ability to slice and dice by different populations. Heart and vascular populations, those with cardiac care is one example of those. And that's sort of what we've done with the data that we have today. And one of the biggest users of those data, so those in the analytics space would understand what I'm saying here. There are several people who have several reports, several dashboards, and use only 2 of them. We're lucky enough to have our heart and vascular group have a fair number of dashboards, but they have a fair use of all of them. So this is clearly an engaged group that actively use the data and interact with us in a manner where they're often looking for ways to refine the information that we've given them. So there's a lot more back and forth, and they use it to manage their populations better, which has allowed them to get recognition with the AHA or the American Heart Association as well.
And so, which is a nice segue back to Evan to talk about, like, part of bringing you two together is saying that there are so many organizations in different industries and groups who are impacting the care that physicians deliver. And so, as you came together with Who We Play For, you had this EKG data, you were able to put it into the cloud, utilizing AI/ML, which told you what about those EKGs?
It told us that it's actually not that difficult with this much data to build an expert tool that's, in the words of AWS's blog post, as good as the experts and pediatric cardiologists, and a lot of proof in the pudding left there. But what we've learned in playing with this data is that we need more help. We really need some more technical help to support Clinton because we have so many projects and it's Christmas Eve for us every day on what we can do. There's so much. And we've tried to laser focus with Mission 1 in this little space that not many people pay attention to, but has been debated for 50 years at the top of the medical ivory tower. Really the primary reason why this is not a standard of care in America, except for elite level athletes and big-time collegiate professional Olympic athletes, and in some cases prisoners in the United States, is because the ability to read an ECG for a kid and a young athlete it's not, America's not very good at this. So the hope Mission 1 is with AWS, with this data set, with Clinton and a bunch more geniuses, we can build a tool that can democratize the ability to read these ECGs and make it agnostic to any ECG machine in the United States or on Earth. So really simple workflows through an app on your phone or through integrating into something like GE's Muse platform if you're in healthcare. But a lot we can do. For me, the biggest one is that, complete Mission 1, empower every doctor in the United States and maybe more to have the ability to read a pediatric and young adult ECG as good as the best pediatric electrophysiologist in America. And then I'll give you this one is, as we've got more data in there, what's been really exciting, we partnered with a lot of groups, people like the Sudden Cardiac Arrest Foundation, people like Dr. Martinez in New Jersey, who has a massive HCM database, again, what our teammate died of and what is the leading cause of death in sudden cardiac arrest under 30. And the exploratory stuff is really exciting. My wife is a sudden cardiac arrest survivor. 8 or 9 years ago when she was 17 years old, she died of cardiac arrest. She was saved, thank God, by an AED. I have a 1-year-old daughter. My wife is idiopathic, which to the tech folks basically means medicine has no clue. We're not there yet. We'll give you every test, but we really do not know. It's a mystery. So with these big AI data set, with AI and with these big data sets, and with people like the SCA Foundation, I'd say my personal priority number 2 is to get to the bottom of these idiopathic sudden cardiac arrest survivors and see if there's a clue. And I hope to God, nothing serious is found really, because I have a 1.5-year-old daughter who's also a perfect picture of health. But a lot of motivation to explore both those questions here.
So Emeka, let's talk a little bit about that. So as physicians, we're trained to talk to our patients. We take a history, we do a physical. We have lots of data available to us. We can order an EKG, we can order a lab, we can get radiographic imaging done. And then we take all that together and we decide, hey, there's a differential diagnosis here, and then ultimately getting to the final diagnosis. Let's talk a little bit about, we've got an advocacy organization who's giving us some data that potentially we can use. And if this were a perfect world from a data standpoint, how would we be able to bring that in so it could be at the fingertips of clinicians who might need it?
In a perfect world where anything I wish for would happen. So in that scenario, there's a large database that you just mentioned. I have, as someone who's actually done plenty of pediatric physicals, and I did not get a single EKG on any of them. It's sad. That is something that I would expect with the data and the knowledge that we have today. As I'm doing the examination, it's already queued up. Here are the things that you actually need to assess. I have a checklist that I can go off, and then it'll easily order those for me. And when I get the information, it's translated for me as well as the patient in a manner that they can understand. So putting that together, it's in a nice, seamless, easy way to not have the physician or the clinical staff have to think as much or have to worry about explaining it to the patient in a manner that is not appropriate or scary or confusing. Those would be the sort of things that I would like to see happen. Right now, we're doing more work on trying to grab, as we recognize that most of the care, the health of the patient, is not actually what happens to them in the hospital. It's actually outside of the hospital. So keyword for our technical folks, which are healthcare folks that recognize social determinants of health. That's a lot more information that we have on people outside of the hospital, that those are the things that actually affect their care. Their ability to basically food security for their medications, how much they can actually understand, what literacy level they understand, so you know how best to explain information to them. Those sort of things would be great to have at the point of care, translated in a manner that I can understand, so I know best how to engage with that patient or that child and their family to help deliver the best care.
And so I really like what both of you are saying. One part of this is, like, now we have more information. We have real life circumstances that have happened. Certainly what was the start of Who We Play For. We continue to hear about more and more people being impacted about sudden cardiac death in the news. Then the next part we have is we have healthcare providers who are saying, we're now ready to put as much information at the fingertips of our providers so that they can really provide that best care. So what's going to be next? Throughout reInvent, we've had a lot of conversation about the use of Gen AI. So one of the things you just said, Emeka, was you wanted to make sure that that information was brought to the patient and to the provider. Evan, you're saying that you want to make sure that everybody, every child who's playing sports has the opportunity to have that EKG so that can be read and interpreted. What else should we be doing? How else should we be looking at all of this emerging technology that's coming, and how should we be looking to use it?
You go first.
Okay. For me, this is one of the things that I am passionate about is literacy, digital literacy. We need to train more of our staff, people, patients, consumers on how best to use the data. Gen AI really blew that out of the water because nobody really knew what artificial intelligence was, and now we are a lot more concerned about it. So knowing how to use that is key, and then growing a group of people who help make sure they audit how people are using it, because inevitable mistakes will occur. And having a group of people that can help mitigate those issues, or when they identify the harm, they help lessen the harm that actually occurs or gets inflicted on the patient, that would be ideal. So literacy is the first thing, and training people up on how to best use the technology or what conditions to apply the technology to would be one of the things that I would like to see happen.
Yeah, running with Dr. Okafor on that, I'd say just lessen the variability in medicine. There's so much variability across practitioners, folks, communities, low socioeconomic, rural, urban, whether it's reading an ECG or delivering the news that, in Rafe's case, you have HCM. And just running down that scenario, the research changes so often. And it's, in a lot of ways, moves at light speed. So if someone's not paying attention, you could be the world's greatest cardiologist, but you haven't paid attention the last couple of years, stayed up to date with, in the case of HCM, the research is showing that most HCM kids can come back and play sports. There's more of a kind of patient, physician choice scenario going on here. And then there's better medication and ICDs and other stuff you can do. So the variability would be great. I think the more we can decrease the variability in medicine, the better. And I think Gen AI might be a great solution for that.
And Evan, can you talk a little bit more about, for Who We Play For, what other organizations are you working with and talking to about how to get these standards out and how to really share this data?
Yeah, 10 years in of the buckshot, trying a bunch of things. We brought together every group like us in the country for this AI project. So there's about 15 nonprofits like us, from the big ones like the Sudden Cardiac Arrest Foundation to dozen plus small ones named after friends and family members who died of sudden cardiac arrest. People like the Cody Stevens Foundation in Houston, y'all's home state. People like the Anthony Bates Foundation in Nevada and Arizona, and a bunch more. With these groups, we've been laser focused on just get the data in. Let's build the very best Mission 1 model we can to democratize the ability to read these ECGs. And then on the back end, having talked for a decade to the top of the medical ivory tower to really identify why is this not a thing in America? What are the barriers? Can there be solutions? And working with state legislators, we've been able to pass 26 laws across a bunch of states. The ones that I'm most excited about are the 7 or 8 in Florida on the school board level who've been able to make ECGs a required standard of care for more than just student athletes in a lot of cases, for marching band, ROTC, dance, sixth graders in some cases, and of course student athletes too. A lot of debate on is a student athlete actually at higher risk, and Who We Play For definitely advocates and believes in every kid having this chance, whether they signed up for high school sports or not. But for us, what's really exciting is decades later of back and forth, these represent the first school districts in the United States to implement this policy. So we've been presenting on this at the Pediatric Cardiology World Congress in DC, at the American Academy of Pediatrics, and a bunch more conferences. One insight would be Orange County, Orlando, Florida. It's the 9th largest district in the United States. In 1 year, we screened around 11,000 kids. There were 304 flagged for follow-up. The criteria you're supposed to read these on has evolved a lot over the last 15, 20 years. There should only be a 2 to 3% flag rate if they're read right. So those 304 kids got worked up. Something like 50 kids had life-threatening heart conditions who needed immediate medical intervention out of that 11,000 pie. And there's a lot of minor abnormalities kids get caught with that they'll need to check in on and monitor, and hopefully be a part of changing the stat on heart disease being the leading cause of death in America. Often these little issues you can maybe have when you're 17 or 18 or even younger can play out into something a lot more deadly as you get older. So it's hard to really quantify the impact we have there. We identify the minor issues, but it's really easy to quantify the life-threatening issues. And one of my favorite stories on that front was we had a girl in a town most of y'all probably haven't heard of, Windermere, Florida. She was flagged with another, HCM, another HCM story. She never had a symptom, like 80% of student athletes. She got a defibrillator put in her chest, and she was at school at Windermere High School, and she collapsed and went into cardiac arrest at school. She's 16 years old. She was dead on her back for 10 seconds on the Windermere High School gym floor, and then stood back up. She didn't know what happened, had a little bit of chest pain, certainly didn't think she died of sudden cardiac arrest. No one in that 100-person gym thought so. She got a call from the cardiology group she works with, the Morris Children's Health, and they said, you need to get in here. So she came in and was delivered the news that that was her first SCA episode, and medicine did its job, and the defibrillator shocked her back to life. But that story starts with a kid who moved from Dallas, Texas to Orlando and found out, I guess I need to get an ECG in Orlando.
And so thank you for sharing that story with us and like a real life example of how the technology aggregating the data led to an intervention that led to saving a life. And we talk a lot about healthcare is a highly regulated industry. I started out by talking about how there are so many different parts of the ecosystem that really play a part in what happens. As you have navigated the complexity of healthcare, who are you talking with? When are you getting together with your peers to talk about what else could you be doing as it relates to data and changing clinical care?
So the Gen AI craze has really helped that conversation, my organization, because we have several well-intentioned groups saying, oh, let's go with this tool or that tool. And that's requiring the whole organization to go, okay, hold on, let's really pay attention to what we're doing here. So we're pulling in our privacy groups, we're pulling in our risk folks, we're pulling in some of our financial folks as well. Now all sitting at the table at the same time with our clinical and operational stakeholders to now discuss what are the use cases, how do we start to govern what information we allow to get put into a certain Gen AI tool, be it public or the one that we've now put into our own ecosystem. So those are the folks that we're starting to pull together. I ultimately feel that the entire care team is who we need to pull in together. So it's not just the people in the business side of the healthcare system, but pulling in the patients, occasionally their families, not just the physicians, but other social workers, care managers, the therapists that go to visit the patient at home. They are all included in how we use the technology, and they are two folks that we need to provide answers to or data insights to as well.
I mean, we're talking about a very specific kind of sudden cardiac death. What are the causes? How can we intervene? But this is a great opportunity to talk about, can everybody really learn more about data? Is there an opportunity to better understand the cloud so that you can take advantage of emerging technology? And so there really is, and that's part of what we're here to do today, is to help spread the word and help inform people on what they can do. So one of the things is, AWS has over 600 modules online. Many of them are free of charge to help learn and do more. If you're really interested in becoming certified, that's an opportunity as well. And then being at a conference like this, where you're able to talk to each other and bring different groups together, that's another way to engage. And once we're able to do that, and people have an understanding, and again, not because they're gonna build an application, but because they wanna better understand and perhaps partner with others, then that can help bring along more people who have really that kind of data, they understand analytics, they have a literacy now that allows them to further engage. So I mean, I really like that opportunity, and I really like talking about it like that. I think one of the things that would be really great to know from both of you is if you could say to the advocacy group, if you could say to healthcare providers, what's the one or two things that they could be doing to make it easier for the other of you?
I'll let you go first.
Yeah, I'm springing that question on
That was
them.
good. That was good. I like it.
What would be easier? Like, when I think about all the people who impact healthcare provider organizations, what would make it easier if they did it a different way?
I can jump in. That helps get some momentum here. I'd
Yeah,
say
you can get started.
I hope this isn't upsetting anybody. I think this is just the absolute reality, is that there's so many people who are unconsciously incompetent, and these are genius doctors who are in their world the absolute best, but aren't open to updates or new things or changes, and who are maybe locked in on the status quo on how things have always been done. Not because data or research supports how they've always been done, but because it was the best we could do decades ago. The questionnaire is one example where we've done a great job, the AHA and many other, American Heart Association and many others, to try and refine and reform the questionnaire to make it actually useful. And in a broad context across a population, I'm with it. Pragmatically, you have to do something like that. It's better than nothing. Empower the pediatrician and others to use things like questionnaire to get at the bottom of family history and symptoms and work them up. But there's never been a study that's shown that actually does anything to reduce sudden cardiac death in a population. Whereas for ECGs, there has been that study. And when you compare these two, one always beats the other. So I think for me, what's most frustrating is I go back and forth in these two worlds of the medical ivory tower to who we play for and many more are representing the grassroots trenches of families and communities who've lived this, who buried their friends and their teammates and their brothers and their sisters, who were screaming and begging for more. And heartbreakingly sometimes a medical community that is busy, doesn't have the ear for it, wants to continue on and maybe not pause and listen as much as we would hope they would. So I'd say to that, I think if folks can just come with, we're not experts at everything, be more open to knowing what you don't know on every side of really all issues, probably change a lot of things.
Yeah, I agree with that. And I would say there's some optimism that I have that at least in the healthcare space, the COVID pandemic actually changed a lot of minds on how we communicate, how we engage, how we recognize that we need to collaborate and move faster. That was clearly the fastest that I'd seen. Prior to that, as you recognize, the only other thing that we focused on that quickly was Ebola, when there was that sort of scare and concern. I would like that sort of energy to be put towards technologies or new insights that we identify. We've clearly shown that we know how to do that. So I'm optimistic that more of that's going to happen. So what I would like is advocacy. It's basically talk to the regulators, right? The governments, payers, the people who pay for the basically dictate what the physicians have to do or how they deliver it. Anything we can do to help decrease that burden, that would be ideal for the providers to make it easier for them to do the right thing.
So when we democratize the data and we make it available to everyone, then we make it easier, right, to share it and for people to be able to ingest it in a way that they can utilize in their daily practice. So I would say there's an opportunity for everybody to be able to utilize the data that's been made available to them, put it in the way that they can understand it, put it at the point of care so that those interactions can be evidence-based and taken at that time. So that would be huge.
Yep.
So no, I appreciate you guys being able to take that question. As we get towards the end, I think there's, for everybody in this audience who is technology focused or provider or healthcare focused as another part of the ecosystem, probably want to know what they could do if they leave here today to help improve access to data, improve clinical care, but very specifically look at sudden cardiac death. So do you want to start, Emeka?
Yeah, so it's going back to literacy. The more you can get familiar with the topics, like you educated me right now as well on things that you brought up here. So that's becoming more knowledgeable. And then taking an action. Whatever avenue you have, talk to your peers or the people above you or the people below you, find out other ways you all can collaborate to do something more with what you have. And I expect that to slowly start to grow. There was one more.
Transparency in the data.
So yeah, also eliminate any data silos, but I'm also just assuming that all the people here we're all bought into it. We drank the Kool-Aid. That we're not necessarily the folks who are hogging, or being siloing the data rather than making it more transparent and pulling in people. So my answer to that was essentially how you collaborate with others is going to help solve this problem. Get more knowledgeable, work on collaboration. That would help.
I think in the context of sudden cardiac death in the young in the United States, there's probably few issues we've ever been advocated less for, considering decades of being #1 cause of death on so many categories. Pretty much pick anything, it's the #1 cause of death in church, in prisons, #1 cause of death in the military outside of nonviolent cause of death, I guess you'd phrase it, or medical cause of death is a better way to phrase it. We haven't really moved the needle. We've spent billions of dollars on AEDs and CPR, things who we play for is advocated for relentlessly and fought like hell for. All stuff we need to do because we all should be ready for a 3 or 4 minute drill like Clinton was when Rafe went down. So for that, I think internally, learn CPR, get familiar with an AED. When you walk into a place or a room, challenge the hotel or wherever, the conference to make sure they have an AED. The last Amazon conference we spoke at while we were talking, someone did die of sudden cardiac arrest in Washington, D.C., while we were talking about sudden cardiac arrest. And I don't know the particulars on if they ended up getting saved or there was cognitive issues afterwards. But when you look behind the curtain here, it's really shocking. And what's more shocking is that in most cases, this is preventable. And when you go down of sudden cardiac arrest, you can be saved. So if you're in this audience and you come away from this thinking, what could I possibly do? I'd say 1, learn CPR, get more familiar with AEDs and how to use them. 2, if you reach out to a group like Who We Play For, we can connect you to other groups in your local community to support these grassroots, often parent-led organizations who are trying to make a difference. And then 3, for your kids and for you, I would advocate for an ECG as a part of the annual wellness checkup or sports physical. And a lot of times you may hear from your pediatrician and others, that's not currently recommended by the AAP. And that's how medicine works a lot of times. It's hard to make a recommendation or requirement for a nation because of the variability, for example, in this case, how that ECG could be read and access to follow-up care afterwards. It's not too different than a couple decades ago, the Surgeon General of the United States refused to say that jogging was a good form of exercise. So this is how this works. Grassroots movements come together, they build coalitions, they work together, they get the data to prove it, they publish it, and eventually the payers and others get behind it. But yeah, this room, I think, could just start with those 3 things.
So, did you have something you're going to add?
Yeah, there was just something else it was more polling the audience again. So how many people know what augmented reality is? How many people played or know someone who played Pokemon Go? Perfect. How many people have seen or used an AED? Wow, actually more than I expected. Wow, that's impressive.
That's really good.
Yeah. So many of us may take a look at an AED and have no idea how to use it. There are some now that are out there that use augmented reality to actually guide the user. It'll open it up while you put on the glasses. It will actually notify 911 for you, so you don't have to now try and figure it out. It will show you exactly where to place the pads. It will measure the depth in which you're doing using computer vision. So I see that as that collaboration that I'm talking about. Clearly, the tech industry that was focused on a tool that was initially looking at gaming is now starting to partner with medical, and then came up with a brand new method that nobody else had thought of at the time. More of those ideas are needed, and that comes with the collaboration.
So what I've heard today is I've heard you talk about what can people go out and do. One is, do you know CPR? Learn it. It's even easier now than it's ever been before. Learn how to use an AED. In your communities, talk about where are the AEDs? Are they readily available? Utilizing data as a technology community, utilizing data that might be disparate, bring it together to become information that then leads to insights that can be used clinically that ends up being the wisdom in which we take care of patients, that we allow this pediatric population to be screened from a cardiac death standpoint, and it allows us to improve the health overall of everyone who's coming in to seek that help within a provider organization. So those are some real things that can happen right now, and that's what can happen when we bring together all parts of this healthcare ecosystem. And so I just want to say thank you to both of you for lending your expertise and your guidance to this conversation today. And thank you to all of you who came and who are very prepared for the future already. But I just want to say thank you so much for being here. And last but not least, would very much like you to go to the app and fill out the survey, or you can use, hopefully do we have the scan code? We do not. So please go to the app, fill out the survey on this session, let them know that you enjoyed it, and next year you won't have to come out to Mandalay Bay because it'll be a little bit closer. Thank you all. Thank you so much.